Hi, I'm Ed Butler. I'm a nuclear medicine technologist at the Royal Free Hospital. Welcome to this session on Renogram processing. Accurate Renogram processing and clear display is important to ensure clinicians can be confident in their interpretation of the results. In this session, I will demonstrate how we process and display renograms at the Royal Free Hospital in order to achieve accurate clinical assessments, and I will discuss potential pitfalls and errors that can arise. There are multiple stages involved in processing renograms. The first step seems fairly obvious. Select the correct images. For the majority of native kidney renograms, posterior images are used for processing, as the kidneys lie more posteriorly in the body. There is therefore less attenuation and background counts from overlying tissues. In some cases, however, anterior images may be necessary, for example, in transplant renograms, where the kidney will lie more anteriorly. When the kidney depth cannot be assumed in the instance of pelvic or horseshoe kidneys, both anterior and posterior images should be used to determine the geometric mean for accurate processing. The next stage is to assess the dynamic images for any patient movement. This may need to be motion corrected if it is significant. ROIs are then drawn and comparisons should be made with previous scans to try to replicate ROIs as closely as possible. Subsequent curves and plots should be assessed alongside sequential images and quantitative values. Windowing should be adjusted accordingly for the images and any labels and annotations added. We currently use Hermes software for processing at the Royal Free. This shows the typical Renogram results page which the clinicians review when formulating their reports. Over the next few slides, I will discuss the individual components conveyed here and best practice methods for achieving accuracy. 120 images are required in total during the dynamic phase of a renogram. In order to display an overview for radiologists, the dynamic images are summed accordingly. Uptake phase on the top row shows the first 5 minutes of tracer accumulating in the kidney. In the first 30 seconds, MAG3 is delivered to the kidneys via the renal vascular supply. This is followed by renal uptake of MAG3 by glomerular filtration and tubular secretion until it reaches a peak during the 2 to 5 minute image on the top row. The bottom row shows post-peak excretion of tracer, with representative summed images of every 5 minutes. These images are useful for getting an overall view of tracer transit through the kidneys. The windowing intensity is increased for better visualization. It is important for the images to be properly scaled. If scaled individually, with each image set to its own maximum, it could result in incorrect visual interpretation with regards to how the kidneys are filling and emptying. The upper level of each image is therefore set to the same maximum to show the true image. The next few slides, I will discuss the regions of interest. To obtain the renogram curves and quantitative data, ROIs must be drawn around areas of interest so that the counts within those regions can be determined. Kidney regions of interest should include renal pelvis, as the renogram should show elimination of radiopharmaceutical into the bladder. You can't assess for pelvic emptying if the pelvis is not included. ROIs that include the renal pelvis generate parenchymal rather than whole kidney renograms. Any retention of tracer in the pelvis will be reflected in the renogram curves. It is important to review later frames, as the renal pelvis may not appear in early images. The cine display should be analysed to ensure the kidneys remain within ROIs if there is any motion. Other structures such as spleen, liver or ureters should be avoided as they can contribute counts erroneously. Kidney ROIs are composed of counts from the renal blood vessels, renal tubules, renal pelvis and overlying tissues. In order to get an accurate renogram and relative function, we must subtract the vascular and tissue background activity so that we are left with the true kidney activity. Tissue background comes from tissues anterior and posterior to the kidney, and it is considered the same bilaterally, with activity increasing over the first few minutes. The assumption is made that the count rates per pixel recorded in the background ROI are the same as in the background non-renal activity present in the renal ROI. Blood within the kidney contributes to the vascular background counts. This must be accurately subtracted by drawing appropriate ROIs. These should avoid the kidneys, bladder and ureter, as it could cause oversubtraction. An obvious point is to keep them inside the body outline, so you will include the relevant counts. It is important to note that MAG3 impurities are excreted via the hepatobiliary system, so regions of interest should avoid the liver. Positioning of background regions is important as it can severely impact results. Remember, it is important to include sufficient tissue and vascular counts to achieve optimum subtraction and true kidney counts. Regions placed solely beneath the kidneys will tend to undersubtract, as not enough blood is included, so the relative function could be wrong. Regions placed above the kidneys will oversubtract, as too much blood is included from the spleen or liver. Perirenal ROIs are frequently favoured for the subtraction of blood and tissue background. They should be drawn slightly separated from the kidney ROIs to avoid scatter, but they can also be suboptimal, as they may oversubtract from the kidney counts. At the Royal Free, we use the Patlack-Rutland method for background subtraction, which is robust and reliable and recommended by BNMS guidelines. Automated background assignments are created that track the kidney ROI, reducing processing time and enhancing reproducibility. The vascular ROI should have as much blood as possible. We use the spleen as it receives blood at the same time as the kidneys. Using the spleen also contains tissue, so must include separate tissue ROIs to account for this. The spleen might not always be possible to use, for instance, if the patient had a splenectomy, in which case alternative vascular ROIs can be the left ventricle or the aorta. Using this method gives greater accuracy in calculating relative kidney function. If background subtraction is optimal, the Renogram curve should start at the origin. Let's look at the Renogram curves. There are three phases. The first phase is the blood phase. It's barely visible in this graph as it has been background subtracted. The second phase initially is a steep upward rise representing the speed of the bolus injection and the delivery to the kidneys via the renal vascular supply. This is followed by a slightly more gradual slope, indicating renal uptake of MAG3 by glomerular filtration and tubular secretion, until it reaches a peak at roughly 3 minutes. This defines the point at which tracer entering the kidney is equal to tracer excreted by the kidney. The time to peak may be delayed in patients with renovascular insufficiency, renal failure, and obstruction. It could also be delayed if there is a poor bolus injection or extravasation. The third phase commences after the peak and falls sharply in normal instances. Renal function is related to the rate and depth to which curves fall. If impaired, MAG3 will remain within the kidney for longer, causing a rising curve or prolonged elimination phase, such as this one. Here you can see the left kidney curve has the pattern we would expect from a normal kidney. However, the right kidney curve continues to rise, indicating delayed excretion. Let's talk about curve smoothing. The processing software can smooth the curves, with a level of smoothing specified by the reporting clinicians. This graph has not been smoothed, so the counts in each frame have been plotted. This can make the graph look noisier, and any patient motion could appear as fluctuations, though in this case it still demonstrates the dynamics of the study well. The second graph has been oversmoothed by a factor of 4, where the mean counts per second in grouped frames have been plotted. As you can see, the curves don't start from 0, which could give the impression that the scan was started late or background correction was suboptimal. This graph has a smoothing factor of 1, denoting that the mean counts per second of every 2 frames are plotted. The curves are less noisy and start from the origin. This is the default setting in our department. Though smoothing affects the curves, it doesn't impact the quantitative analysis for relative function. Outflow efficiency is expressed as the percentage between the total outflow and total inflow into the kidney over time. For healthy people, it should be above 82% after 20 minutes, meaning 82% of activity flowing into the kidney should have flowed out. This can be useful for quantifying renal clearance in possible obstruction. As can be seen in this graph, there is a reduced outflow in one of the kidneys due to obstruction. The quantification results are displayed, including the outflow efficiency expressed as a percentage. Renal size may assist in detection of undetected bilateral increases or decreases in renal size and facilitate scan interpretation, as several chronic renal diseases will result in bilaterally small kidneys. Conversely, the kidneys may be bilaterally enlarged in early diabetic renal disease, acute interstitial nephritis, HIV nephropathy, and amyloidosis. One of the key parts of the Renogram results is the relative function, which we will talk about now. Relative or differential function is the proportion of activity that goes to each kidney, expressed as a percentage, and reflects the amount of work that each kidney is contributing. In normal working kidneys, this tends to vary between 40 and 60%. It should be measured after mixing in the blood is complete and before elimination from the kidneys commences. Background subtraction should be correct, and kidneys are assumed to be the same depth. Then the counts in the kidneys can be considered proportional to function. There are two main methods we use for calculating renal function. First is the integral method. This compares the area under the kidney curves during the uptake interval. Our default setting is from 1 to 2 minutes. This way, it avoids unreliable counts during the mixing phase in the first 60 seconds, and finishes before the Renogram peak. The total counts under each curve are summed, and the relative function is then the fraction of the total for each kidney. The integral method is accurate and easily reproducible between operators, and the time points can be adjusted in the case of early or delayed start time. The second method is the Rutland-Patlak method. The computer generates a plot for each kidney. This is the mathematical model that simulates what would happen if the blood activity were constant. On the x-axis is a normalized time, which is the ratio of the running sum of blood pool activity divided by the point-by-point blood pool activity. The y-axis is the kidney counts per second divided by the blood counts per second. This method allows for different blood background in each kidney. The slope corresponds to the uptake phase, and in real time this is normally between 60 to 150 seconds. The intercept gives the blood background subtraction factor. The slopes are a measure of kidney function, and the ratio of the slopes gives the relative function. Errors can arise if the program chooses the incorrect fit. If the scan is started too early or late, the start and end range may need to be adjusted as the Patlak is set to a specific time frame. This can introduce intra-operator variability that can affect function calculation. Therefore, the start and end range should not be changed unless absolutely necessary. The Rutland-Patlak method is considered the most reliable method to calculate relative function. When reviewing the Patlak plot for quality control purposes, some points need to be considered. There should be no scatter, and the lines should be clearly linear for 3 minutes with clear intercepts. If the uptake phase isn't on a straight line, it could be related to the position of the blood ROI. Pre- and post-micturition images should be acquired for all Renogram studies. The images are acquired with the patient standing with their back to the camera and the bladder in the field of view. ROIs are copied onto the images so that counts can be plotted on the Renogram curves. Post-micturition images are valuable because back pressure from an overfilled bladder may prevent the kidney drainage and so mimic obstruction. These images are useful if the scan is terminated early, as it helps to better evaluate the drainage. The pre- and post-micturition images must be scaled to the same maximum as the summed images, so that kidney changes are obvious. To evaluate the diuretic response, the voided volume is measured. Urinary flow is calculated from the time interval from pre-scan void to post-scan void, and this can alert to inadequate diuresis. A patient with normal renal function should produce about 200 to 300 milliliters of urine in 20 to 30 minutes after receiving 40 milligrams of furosemide. The volume voided and diuresis rate should be included in the results page. To summarize, a good Renogram display should include summed images, ROIs drawn using the Patlak method, Renogram curves with correct background subtraction, quantitative results displaying the relative function, Pat-like plot for calculation of relative function, outflow efficiency curves, and finally, pre and post mixed images that have been properly scaled. Here are some of the key points. Use the Pat-like method for regions of interest. Vascular regions should be over the spleen and tissue background below the kidneys. Be sure not to exclude the renal pelvis. If background subtraction is optimal, the curves should rise smoothly from zero. Pat-like plot is the best for calculating relative function. Finally, summed images and statics should be scaled to the same maximum. I'm just going to touch briefly on indirect micturating cystography. This is used for detecting vesicoureteric reflux. A routine renogram is acquired first and processed normally. The patient then either sits on a commode or can stand if they are male, with their back to the camera, and a set of dynamic images at 1 second per frame is acquired, whilst the patient voids their bladder and stopped when voiding is complete. ROIs are placed around the kidneys and bladder with careful attention paid to any movement. ROIs over the ureters are not considered helpful. Time activity curves are then generated. On this display, each image represents the sum of 10 1-second frames. Time activity curves show activity in the kidneys and the bladder. This was a positive scan for reflux, seen in the left ureter and pelvic calyceal system. You can note that the left kidney appears hotter around the 3-minute mark during micturition, and this corresponds with the peak in the left kidney curve. There is also some more moderate reflux seen in the right kidney. Due to the short frame rate, the curves can appear noisy, so sometimes increasing the smoothing may be beneficial for interpretation. This set of images is from the same study, with the images summed every 5 seconds. And you can notice that the activity appears more intense in the left kidney, around 3 minutes. Let's talk about the pitfalls and errors that can occur during processing. Infiltration of a substantial fraction of the administered activity causes activity to continue entering the bloodstream throughout the acquisition and can lead to a renogram curve suggesting delayed uptake and delayed washout. The presence of infiltration can be assessed by a short image over the injection site at the conclusion of the study. A poor bolus injection can also cause a prolonged time to peak and inaccurate differential function. Inadequate hydration can produce a renogram pattern that mimics obstruction. If the acquisition is started too early or late, this will affect the renogram curves and possibly the relative function calculation. Patient movement can result in the kidney not being covered by the ROIs. Check that the ROIs correspond to the correct kidneys. Are the blood and tissue backgrounds optimal? Incorrect windowing can lead to incorrect interpretation. Not matching ROIs to previous studies could result in incorrect comparison. If the kidneys are not the same depth, then attenuation will be different. Finally, don't mistake the gallbladder for the kidney. If the acquisition is started late, it could mean the vascular phase of the renogram is missed when the tracer is delivered to the kidneys. This may result in incorrect background subtraction and miscalculation of relative function. When the acquisition is started too early, the curves are shifted to the right, with dead time before the activity reached the kidneys. The uptake phase has been shifted, so if the Patlack and integral limits are set to a specific time, then counts from the mixing phase could be included instead of the uptake phase, so relative function will be incorrect. It may be possible to adjust the specific time frames and adjust the Patlack plot manually to correct this. Here is a scan that was started too late. You can see a high amount of activity already present in the kidneys in the first summed image. The curves have almost peaked from the beginning, so the vascular and uptake phase were virtually completely missed in this study. This meant that vascular background subtraction was incorrect, so the blood ROI was not included, and the relative function calculations could not be relied upon. The cine should be reviewed for movement before drawing ROIs. The regions of interest are fixed, so patient motion during the study may cause a portion of the kidney or renal pelvis to be excluded from the ROI, resulting in spurious renogram curves or quantitative indices. If it is significant, motion correction may be required. If it is minor, care should still be taken to ensure the kidneys remain within the regions of interest for all frames once they are drawn. Can anyone spot the error here? Looking carefully at our landmarks, we see the liver appears on the left side of the image. If this was a posterior projection, we would expect to see it on the right-hand side. Also, the kidney ROIs are labelled incorrectly. It also appears as though the blood ROI is positioned over the aorta. However, it also incorporates part of the liver. As mentioned earlier, the liver should be avoided as MAG3 impurities are excreted via the hepatobiliary system. Please check for anatomical landmarks and select the correct posterior projection for native kidney scans. This is the correct image. The liver now appears in the correct position on the right-hand side of the posterior image. The pre- and post-MICT images were acquired supine due to patient immobility. However, the detector configuration was not changed to account for this, so only the anterior projection was acquired. Therefore, it was not included on the Renogram plot. This demonstrates incorrect scaling of images. It gives the impression of incomplete drainage. Summed and pre- and post-micturition images should be scaled to the same maximum and not to their individual maximums to show the true picture. We normally assume the kidneys to be of similar depth and therefore experience similar attenuation. This is not always the case. For example, when a patient has pelvic or horseshoe kidneys. Use of the geometric mean is likely to provide a more accurate assessment of divided function, given that the counts obtained from an anterior structure within the body will be attenuated by body tissues and pelvic bones when just the posterior images are used to assess the divided function. Therefore, we must use ante and post images when processing. Here in this example, the patient had a pelvic kidney lying more anteriorly in the body. In this display, only the posterior images were used for conventional processing. Note the markedly different relative function between the two kidneys. This is the same renogram reprocessed using anterior and posterior images for the geometric mean. The relative function is now within normal range. Just a brief point about captopril studies. These are performed in order to characterize renovascular hypertension. In order to accurately compare the two acquired renograms, it is important to ensure the ROIs are closely matched. Here is the baseline study. Note the renogram curves. Here is the post-captopril study on the same patient, showing a normal left kidney. Although this split function does not change between the two studies, there is clearly a delay in transit of the tracer from the renal parenchyma to the collecting system on the post-captopril study, with corresponding shift in the renogram curve for the right kidney. Decreased flow rate in the right kidney on the post-captopril study is in keeping with renin-dependent renovascular hypertension. Finally, sometimes activity in the gallbladder has been mistaken for renal activity, and delayed images may show bowel accumulation. A small fraction of the administered dose of MAG3 is transported to the gut via the hepatobiliary system. This fraction increases in patients with impaired renal function. Any regions of interest should exclude this. To summarize, accurate processing is essential for clinicians to be confident in their conclusions. Watch out for those pitfalls. Thank you for listening to this talk on renogram processing. If you have any questions, please join us for the Q&A session later on and our interactive sessions this afternoon.